Mechanical ventilation does not have to be intimidating. Whether you are a hospitalist, internist, or a non-ICU doc who just wants to feel more prepared when your patient gets intubated, this video is for you. I'm breaking down 9 must-know concepts that will help you understand mechanical ventilation and communicate confidently with the ventilator. I'm pretty sure after this you won't shy away from the ventilator again. So grab a coffee and let's finally make sense of mechanical ventilation. Let's get started. Let's start with the first concepts. The respiratory cycle has 2 phases: expiration and inspiration. Inspiration is an active process that requires energy. Expiration is typically passive, relying on the natural elastic recoil of the lungs. The duration of the respiratory cycle is calculated by dividing 60 seconds by the respiratory rate. This cycle encompasses both inspiratory and expiratory times. The relationship between inspiration and expiration is not equal. Physiologically, the ratio of inspiratory time to expiratory time, i.e. ratio, is typically 1:2 or 1:3, with expiration being longer than inspiration. For instance, if a patient's respiratory rate is 20 breaths per minute, their respiratory cycle would be 3 seconds, 60 divided by 20 per minute. Given the physiologic, i.e. ratio, the inspiratory time would approximately be 1 second and the expiratory time would approximately be 2 seconds. Let's move to the second concept. The ventilator does the heavy lifting during inspiration, but it does not clock out during expiration. As we mentioned earlier, inspiration is an active process that requires energy, so the ventilator works mainly during this active energy consuming phase. But that does not mean the ventilator just shuts off during expiration. It continues to play a crucial role by maintaining a certain level of pressure that is called PEEP, or positive end expiratory pressure. PEEP prevents the alveoli from collapsing at the end of expiration by holding a small amount of pressure in the lungs throughout the entire respiratory cycle, not just during expiration phase. Think of it as a doorstop that keeps the alveoli slightly open, making the next breath easier and improving oxygenation. So please do not be fooled by the name PEEP. PEEP is not just at the end of expiration, it's present throughout the entire respiratory cycle. During expiration, it's the only pressure applied, and during inspiration, the ventilator adds pressure on top of PEEP to deliver the breath. Take a look at this pressure versus time graph on this ventilator screen. The yellow line represents the PEEP and the green line represents the inspiratory pressure that is added on top of the PEEP. Let's move to the third concept. Air flows from areas of higher pressure to lower pressure. During inhalation, air enters the lungs because the pressure at the nose and mouth is higher than the pressure in the alveoli. During exhalation, the process or the pressure in the alveoli becomes higher than the airways opening, so air flows out. This air movement continues as long as pressure gradient exists. In spontaneous breathing, we actively lower the pressure inside our alveoli below the atmospheric pressure. This creates suction effect and pulls air in. In mechanical ventilation, the ventilator does the opposite. It raises the pressure at the nose and mouth above alveolar pressure to push the air in. That's why we call it positive pressure breath. So to sum it up, in spontaneous breath, we suck the air in, while in positive pressure breath, the ventilator pushes the air in. Before we continue, if you'd like to receive a written summary or version of this content, something you can refer back to, save, or even print it out, kindly subscribe to my Substack. The link is provided in the description field. It's free to subscribe, and I post regularly with practical, high-yield clinical content over there. Let's move to the fourth concept. To get air in, the ventilator has to fight 3 battles: the tube, the airways, and the lungs. During mechanical ventilation, the ventilator delivers air through the endotracheal tube, down the airways, and into the alveoli. To do this, it must overcome 2 main types of resistance: the airway resistance from the ET tube and conducting airways, and the elastic resistance from the alveoli and the lung tissues. The resistance in the ET tube and airways is primarily due to their narrow lumens and flow dynamics. The pressure required to overcome this kind of resistance is called resistive pressure, and it's calculated by multiplying the flow rate by the airway resistance. So resistive pressure equals flow times resistance. In contrast, the alveoli are evaluated based on their compliance, their ability to stretch and accommodate volume. The pressure required to overcome alveoli and lung tissues stiffness is called elastic pressure, and it's calculated by dividing volume by compliance. So elastic pressure equals volume divided by compliance, and in mechanical ventilation, the volume here simply represents the tidal volume and the elastic pressure represents the alveolar pressure. So the equation can be rewritten as alveolar pressure equal to tidal volume divided by compliance. Therefore, for a full breath to be delivered, the ventilator must generate enough total pressure to overcome both the resistive and elastic or alveolar pressure. In mechanical ventilation, the pressure required to deliver a breath is called the peak inspiratory pressure. Let's rewrite the equation again. Peak inspiratory pressure, PIP, equal resistive pressure plus elastic or alveolar pressure, which means the PIP equal flow times resistance plus tidal volume divided by compliance. So you can see here that peak inspiratory pressure is proportionally related to flow, airway resistance, and tidal volume, but inversely related to the compliance. This equation is the backbone of mechanical ventilation. Please keep it on your phone to come to it every time you try to troubleshoot peak inspiratory pressure or flow issues. Take a peek at this ventilator screen. The PIP here, peak inspiratory pressure, is 20 centimeter H2O. The flow rate is set to 44 liter per minute and the tidal volume 500 ml. Guess what will happen to the PIP if I increase either the flow or the tidal volume? So based on the equation, the peak inspiratory pressure will go up, correct? Now what will happen to the PIP if the patient bites the endotracheal tube or develops bronchospasm, both of which increase airway resistance? Again, you will see a rise in the peak inspiratory pressure, the PIP. Now, let's say the patients develop pulmonary edema and bilateral pleural effusion. What would happen to the peak inspiratory pressure in such a case? Now, pulmonary edema and bilateral pleural effusions are conditions that will reduce the alveoli ability to accommodate tidal volume, which means reduce their stretchability and compliance. PIP, peak inspiratory pressure, is inversely related to compliance. Now, the ventilator has to push harder to get the breath in, which means higher peak inspiratory pressure. Let's move to the fifth concept. Plateau pressure is your window into lung compliance. Let's imagine a moment when the flow drops to zero. This occurs briefly at the end of inspiration just before expiration begins, and again at the end of expiration just before the next inspiration starts. These are the transition points between phases of the respiratory cycle when there is no airflow, because the pressure between the airways and alveoli are equal, no pressure gradient. Guess what happens to the PIP when the flow drops to zero? Let's go back to our equation. PIP equal flow times resistance plus tidal volume divided by compliance. If the flow drops to zero, the resistive component disappears and the equation simplifies to PIP equal tidal volume times divided by compliance, which equals alveolar pressure. This means when the flow is zero, the PIP is equal to the alveolar pressure again, and this makes sense as pressure gradient means flow and the absence of the gradient means no flow. In mechanical ventilation, the pressure that is measured at the end of inspiration when the flow is zero is known as the plateau pressure. Plateau pressure provides a great insight into the lung compliance. The lower the plateau pressure is, the more compliant the lung is, the more compliant and stretchable, and less stiff the lung is, and vice versa, of course. So how do we measure the plateau pressure? Simply, we perform what we call the inspiratory pause or hold maneuver. Take a look at this video here where I perform the inspiratory pause maneuver. It is the white line of the curve. It pauses before going into expiration, the yellow line, to measure the plateau pressure, which was 29 centimeter H2O in this case. In clinical practice, we aim for a PIP less than 35 centimeter H2O and a plateau pressure less than 30 centimeter H2O. So far we've been talking about the pressure at the end of inspiration and before expiration valve opens, but how about the opposite? I mean, the pressure measured at the end of expiration and before the inspiration valve opens. What do you think the alveolar pressure should be equal in such case? We mentioned earlier that the only pressure that ventilator provides during expiration is the PEEP, correct? This means the expiratory flow will continue until the alveolar pressure is equal to the PEEP when the flow then ceases. So normally the pressure measures at the end of expiration when the flow is 0 must equal PEEP value. To confirm that, we perform what we call the expiratory pause or hold maneuver. This maneuver allows us to check for any gas trapping and auto PEEP. Let's move to the sixth concept. The ventilator cannot think for itself. It needs our guidance. So please give me your full attention here. For the ventilator to function properly, we have to give it 5 instructions. The first one, when to start the breath, then how to deliver the breath, when to terminate the breath, how much oxygen to give, and how much PEEP to give. Let's start with the first point, when to start the breath or inspiration. The ventilator will listen to the patients to detect the patient's any inspiratory effort. It will pick up any effort as a sign that the patient is trying to breathe, and it will go ahead and assist the patient with that breath. This is known as patient's triggered breath, or as we call it in mechanical ventilation, an assist breath or a breath. But what happens if the ventilator does not detect any patient's trigger? Let's say the patient is paralyzed or brain dead. In this case, the ventilator has a built-in safety mechanism. It will deliver a breath if no patient's trigger is detected for a specific period of time. This is called a backup breath, or as we call it in mechanical ventilation, a controlled breath or C breath. Take a look at these two ventilator screens. The breath on picture A is a controlled breath or backup breath labeled as C breath, and the breath on picture B is an assist breath that was triggered by the patient and assisted by the ventilator. You see the A letter. But what decides how long the ventilator should wait before delivering a backup breath? This timing is based on the set respiratory rate, also known as the backup rate. This is the minimum numbers of breaths per minute the patient receives, even if they make no effort to breathe. The ventilator will listen to the patient for a period equals to 60 seconds divided by the backup respiratory rate before delivering the backup breath. For example, if the backup rate is 15 breaths per minute, the ventilator waits up to 4 seconds, 60 divided by 15, and if no patient's trigger is detected within 4 seconds, a backup breath will be delivered. It's important to notice here that the actual respiratory rate can be equal to or higher than the backup rate, but never lower. This is important when trying to adjust the backup rate. Let's say the backup rate is 14 and the patient is breathing at 20 breaths per minute. This is the actual rate. There is no point here if you increase the backup rate to 16 because the patient, the actual respiratory is already higher. So take a look at this ventilator screen. You can see the backup rate set at 18 while the actual respiratory rate on the ventilator is 28. So to increase the backup rate will not have values unless you go above the actual respiratory rate. And by the way, the pieces of information at the bottom of the picture are the set values that we provide, while those at the top are the actual live values. Let me quickly go over how the ventilator detects the patient's trigger. In spontaneous breathing, the patients generate a negative pressure, as we mentioned in the alveoli. This creates a suction effect that pulls air in. When the patient is intubated and connected to a ventilator, this same effort draws air through the circuit, and that's how the ventilator knows it's time to assist the patient with their breath. Take a look at the ventilator circuit here. You will notice two limbs connected to the endotracheal tube. The inspiratory limb, which carries air from the ventilator to the patient, often passing through a humidifier, and the expiratory limb, which returns air from the patient back to the ventilator. When the patient is not making any effort, air flows equally through both limbs. But when the patient initiates a breath, they pull some of the air from the inspiratory limb into their lungs, reducing the flow returning through the expiratory limb. The ventilator senses this imbalance and interprets as an inspiratory effort. It will go ahead and assist the patient with that breath. This is called a flow trigger. Alternatively, the ventilator can detect a drop in airway pressure caused by the patient inspiratory effort and use that as a trigger. This is called a pressure trigger. To summarize, the ventilator can recognize a patient's attempt to breathe in two ways: flow trigger by sensing a drop in the flow through the expiratory limb, and a pressure trigger by sensing a drop in airway pressure. Take a look at these two screenshots of two ventilators. On picture A, the the word P sense shows the pressure trigger. It's set at 2 centimeter H2O, meaning the patients must reduce the airway pressure by at least 2 centimeter H2O to trigger a breath. We usually set it between 2 and 3 centimeter H2O. On picture B, the V sense word represents the flow trigger set at 3 liter per minute. This means the patient must draw in at least 3 liter per minute, approximately 50 ml per second, for the ventilator to deliver a breath. Now, whether using a flow trigger or pressure trigger makes no clinical difference. Neither offers a clear advantage over the other. Now, the ventilator is about to deliver a breath, whether an A, assist breath, or control breath, C breath. In which way should the ventilator deliver the breath now? In mechanical ventilation, we refer to the way of delivering the breath as the target. And although the term can be confusing, the concept is straightforward. Just give me your full attention here. Let's bring back our lovely equation again. The PIP equal flow times resistance plus tidal volume divided by compliance, which can be rewritten as PIP equal flow times resistance plus alveolar pressure, and then rearrange that flow equal PIP minus alveolar pressure divided by resistance. In mechanical ventilation, we can directly set the flow rate and the peak inspiratory pressure on the ventilator. However, alveolar pressure and airway resistance are not directly settable. They are influenced by the patient's lung mechanics and underlying conditions. Now, based on the equation, mathematically, for the pressure flow and flow relationship to hold true, we can only set one variable, either the pressure or the flow, but not both. That's because one of them must remain flexible to allow the other to stay fixed. If we fix both, the equation would not hold under changing patient conditions. This will leave us with one of two options to deliver the breath. You can either set the flow and let the pressure adjust, which is called the flow target, or set the pressure and let the flow adjust, which is called pressure target. In flow target ventilation, we start by setting the desired flow rate. From there, we have two main subtypes based on how that flow is delivered. We can ask the ventilator to keep the flow rate fixed throughout the inspiratory phase, which will result in a square or rectangular flow versus time curve. Or we can ask the ventilator to give the set flow rate only at the beginning of the breath, then let the flow rate progressively drop or decelerate throughout the rest of the inspiratory phase. This will result in a decelerating ramp flow versus time curve. In clinical practice, we primarily use the decelerating ramp flow curve, as it generally results in a lower peak inspiratory pressure compared to, of course, to the constant square flow pattern. Take a look at this flow target on the ventilator screen. The green curve shows the decelerating ramp flow pattern. And on the bottom info panel, the flow target is set at Vmax 44 liter per minute with the ramp type set to decelerating ramp. Now, what do you think will happen to the PIP if we set Vmax at 70 instead of 44? If we increase the Vmax to 70 instead of 44, in flow target ventilation, the peak inspiratory pressure will increase. That's because in flow target modes, pressure and flow are directly related. A higher set flow requires more pressure to deliver the breath, as we mentioned in the equation, resulting in a higher PIP. On the other hand, setting a lower flow would reduce the pressure needed, leading to a lower PIP. And usually we set the flow rate between 40 to 60 liter per minute. How about the pressure target ventilation? Here we tell the ventilator to apply a fixed amount of pressure on top of the PEEP throughout the inspiratory phase until the breath is delivered. So what do you think the flow pattern will be in pressure target? So to maintain a fixed pressure throughout the inspiratory phase, the flow must progressively decreases to keep the equation valid. Remember the equation, flow equal PIP minus alveolar pressure divided by resistance, of course, as long as the resistance is constant. That's why the flow versus time curve is always a decelerating ramp curve shape in pressure target modes. Take a look at this ventilator screen. See the fixed pressure here. The ventilator adds 20 centimeter H2O on top of PEEP of 5 and keeps it there during the whole inspiration. The flow curve is a decelerating ramp curve. Now, what do you think will happen to the flow rate if we set the inspiratory pressure at 30 centimeter H2O instead of 20? If we increase it to 30 from 20, the flow rates will increase. So the higher we set the pressure, the greater the initial flow the ventilator will deliver. Now, having discussed when the ventilator initiates a breath, the trigger, and how the breath is delivered the target, let us now turn our attention to when the ventilator should stop delivering the breath, a phase known as the cycle in mechanical ventilation. In mechanical ventilation, there are three main mechanisms to determine when the ventilator stops inspiration and switches to expiration. These cycling mechanisms are: number one, volume cycle ventilation. And in volume cycle breath, the ventilator switch from inspiration to expiration once the preset tidal volume is delivered. Look at the ventilator screen and see how the volume versus time curve. Once it reaches the desired tidal volume, it will switch from the green color inspiration, which represent inspiration, to the yellow color, which represent expiration. Also look at the top panel and see that the actual tidal volume was 315, not the set tidal volume. In reality, the ventilator doesn't always fulfill the exact set tidal volume, but it will be close to that. What do you think will happen to the inspiratory time if we increase the tidal volume here? Of course, it will increase it. The larger the volume, tidal volume, the longer it takes to deliver it, and the opposite is true. Now, the next way the ventilator used to terminate a breath and cycle from inspiration to expiration is time cycle ventilation. In time cycle breath, the ventilator switches to expiration after a preset inspiratory time has elapsed, regardless of the volume delivered. Check this ventilator screen for the set inspiratory time and see that the green line in all the curves switches to yellow after the set inspiratory time elapsed. Now, what do you think the tidal volume will be if we shorten the inspiratory time? It will be, of course, smaller, as we're spending less time delivering the breath, and the opposite is true. Let's move to the third way the ventilator uses to cycle from inspiration and to expiration is flow cycle ventilation. In flow cycle breath, which is used primarily in pressure support mode, we'll come to that later, the ventilator ends inspiration when the inspiratory flow drops to a preset percentage of peak inspiratory flow. Look at the screen and see that the word E-sense or expiratory sensitivity settings commonly set at 25%. The breath ends when the flow falls to 25% of its peak during inspiration. What do you think will happen to the tidal volume if we set a E sensitivity at 50% instead of 25%? It will be smaller, as we are having shorter inspiratory time, and the opposite is true. Now, the final two parameters the ventilator needs to know after providing the instruction about the trigger, target, and cycles are related to oxygenation. The FiO2 and the PEEP, we will dive deeper into how these affects oxygenation later in this video. Now that we have covered the foundations of mechanical ventilation, it's time to explore the core modes used in clinical practice. And this brings me to the seventh concept, or concept number 7. Every mode is a recipe, you just change the ingredients. Think of each ventilation mode like a recipe the ventilator follows to deliver a breath. The basic components of the recipe don't change, but how we mix them does. At the heart of mechanical ventilation, there are three fundamental modes: volume control, pressure control, and pressure support. Every other mode you will encounter is either a hybrid or a modification of these three basic modes. And to make sense of any mode, we just break it down into the three key ingredients we just explained: the trigger, what starts the breath; target, how to deliver the breath; and cycle, what ends the breath. Now, before I go further, if you are finding this helpful, you are going to love my full mechanical ventilation course. It covers everything we are walking through in this video, from triggers, target, and cycling to all the core modes, plus much more, like troubleshooting peak inspiratory pressure, rise time, mean airway pressure, auto PEEP, gas trapping, assessing weaning readiness, and how to do a proper weaning trial. It's designed to walk you through mechanical ventilation step by step in a way that's clear, visual, and practical. So if you are ready to truly master the ventilator and feels confident at the bedside, check out my course. The link is provided in the description field. Let's go back and start with the volume control mode. Volume control mode, or VC mode, uses what we call the AC trigger, which assist control trigger. And as we explained earlier, this means the ventilator delivers a breath either when the patient initiates one, or if the patient does not, the ventilator will trigger the backup breath or C breath. VC mode volume control use a flow target to deliver the breath, most commonly using decelerating ramp flow pattern. And the volume control use volume cycle, meaning the breath ends once the preset tidal volume is delivered. So when ordering VC or volume control mode, in addition to providing FiO2 and PEEP values, we need to provide the following to the respiratory therapist: the backup respiratory rate, the preset tidal volume, the flow curve, square or decelerating. I always go with decelerating, the peak flow rate, and in most cases, the respiratory therapist will by default pick a decelerating ramp flow curve and set the peak flow rate by themselves. A reasonable starting peak flow rate is between 40 to 60 liters per minute. Take a look at this VC or volume control mode screenshot. The trigger, as you see, is AC, and that specific breath was a controlled breath. The backup rate is set at 18, and this is again the minimum respiratory rate the patient will have. The target is a flow target with a peak flow rate set at 44 liters per minute with a decelerating ramp curve, and the breath will terminate once the 500 cc is delivered. Let's move to pressure control mode. Trigger here, similar to VC mode, it uses AC triggering, meaning again the patient can trigger his breath, and if not, the ventilator will deliver a backup breath. The target in pressure control mode, from its name, is pressure target. The ventilator delivers a breath by applying a set inspiratory pressure above the PEEP and adjust the flow as needed to maintain that fixed pressure throughout the inspiration. The cycle in PC mode is time cycle. The breath ends when the set inspiratory time has elapsed, regardless of how much tidal volume was delivered. Now, when ordering PC mode, again, in addition to the FiO2 and PEEP that we provide in all modes, we need to provide our respiratory therapist with the following values. Again, backup respiratory rate, the PI or inspiratory pressure value. This is the pressure that will be added on top of the PEEP during inspiration. TI value or inspiratory time. This is the time that the inspiratory pressure will be applied for. It's usually I use 0.9 to 1.1 seconds. Take a look at this PC mode screenshot. The trigger again is AC. The backup rate is 18. The inspiratory pressure or PI is set at 20 centimeter H2O, and the inspiratory time TI is set at 1.1 seconds. How about pressure support mode? The trigger in pressure support mode is patient's trigger only. There is no backup respiratory rate. That's why it's suitable only for awake, spontaneously breathing patients, typically during weaning phase of mechanical ventilation. So there is no backup rate. Pressure support mode is a pressure target mode, similar to the PC mode. The ventilator delivers a breath by applying a set inspiratory pressure above the PEEP to assist the patient's spontaneous effort. But the cycle in pressure support mode is flow cycle. The breath ends when the inspiratory flow decreases to a preset threshold, usually set at 25% of the peak inspiratory flow. Now, when ordering pressure support mode, usually in weaning, in addition to FiO2 and PEEP values, we provide the respiratory therapist with the inspiratory pressure, or what we call pressure support in the pressure support mode, and the flow cycle percentage, typically 25%. Again, you see there is no backup respiratory rate here because it only uses the patient triggers. Take a look at this screenshot of the PS mode. The breath labeled as S breath, meaning spontaneous breath. There is no backup rate. The target here is labeled as pressure support or P support, and the E sensitivity is the flow cycle set at 25%. Let's move to the 8th concept. No mode is perfect. Each mode has its advantages and limitations. For example, in volume control VC mode, you are guaranteed a set tidal volume, but there is no limit on how high the peak inspiratory pressure can go. While in pressure control mode, the PIP, the peak inspiratory pressure, is controlled and won't exceed the set level, but the tidal volume can vary from breath to breath depending on the lung compliance and resistance. And pressure support mode, which is typically used for weaning, functions similarly to PC pressure control mode. It limits the PIP but does not guarantee a fixed tidal volume. Now, how about if I take the good stuff from each mode? For example, if I take the set tidal volume from the volume control mode and combine it with the controlled inspiratory pressure from the PC mode or pressure control. Well, that's exactly how PRVC, pressure regulated volume control, was born. In PRVC, you set the tidal volume you want to deliver, and you also provide a maximum pressure limit. This acts as a safety cap, not the actual pressure used in each breath. And here's how it works. The ventilator adjusts the inspiratory pressure breath to deliver the set tidal volume while keeping pressure as low as possible. If the patient's lung compliance worsens, like in ARDS, the ventilator will increase the pressure to try to maintain the tidal volume, but only up to the set pressure limit. If compliance improves, the ventilator then will lower the pressure accordingly, so it's not fixed pressure. If the pressure needed to deliver the tidal volume exceeds the set limit, the ventilator won't go higher. It will under-deliver the volume and often trigger a low tidal volume alarm. That's why choosing a reasonable pressure limit is important, especially in patients with stiff lung. 35 to 38 centimeter H2O are reasonable values. Now, some ventilators also require or allows you to set an inspiratory time, TI and PRVC mode. If used, TI or inspiratory time helps shapes how long the inspiratory pressure is applied. A longer TI can help improve alveolar recruitment and oxygenation in patients with stiff lungs, while a shorter TI inspiratory time may be needed in patients with obstructive lung disease to prevent air trapping. So in addition to FiO2 and PEEP, the following parameters are typically set in PRVC. The backup respiratory rate, since it uses an AC trigger, tidal volume because it's volume cycled, the maximum pressure limit as a safety guard to prevent barotrauma, inspiratory time or TI, this is on some ventilators only to control the duration, pressure delivery, and fine-tune the IE inspiration-expiration ratio. Now, SIMV synchronized intermittent mandatory ventilation is essentially a blend of VC or PC with pressure support modes. I won't dive deeper into SIMV here as I rarely use it in clinical practice today, and there is no strong clinical justification for choosing it over other modes. In fact, current evidence does not support the superiority of one mode over the other in terms of clinical outcomes for patients with acute respiratory failure or other critical care conditions. The choice of ventilation mode should always be individualized based on the patient's clinical status, lung mechanics, and response to therapy. I personally like PRVC as it may offer advantages in terms of lower peak inspiratory pressure and more stable gas exchange, making it a reasonable first choice among the three modes. Let's move to the final and ninth concepts: tuning the ventilator, oxygenation versus ventilation. When managing a ventilated patient, it's crucial to understand what you are trying to fix. Are you trying to improve oxygenation, ventilation, or both? Because these are two distinct goals and each is managed by adjusting different ventilator settings. To improve oxygenations, we focus on increasing FiO2 and PEEP. And to improve ventilation, we adjust the tidal volume and inspiratory rate to control the CO2 removal. Now, knowing which knob to turn allows you to make targeted, effective changes based on your patient's needs without overcomplicating things. In hypoxic patients, I typically start with an FiO2 of 100% and a PEEP value of 10 centimeter H2O. From there, I aim to wean the FiO2 as quickly as possible, targeting equal or less than 60% to minimize the risk of oxygen toxicity. I avoid reducing PEEP until FiO2 is down to 60% or less. If I cannot lower FiO2 safely, I will consider increasing PEEP value, usually in increments of 2 to 4 centimeter H2O to improve oxygenation. But keep in mind, raising PEEP will also increase your peak inspiratory pressure. Now, for refractory hypoxemia, there are additional advanced strategies that could be used, such as recruitment maneuvers, using paralytics for a short period of times, if there is desynchrony, inhaled pulmonary vasodilator, and ECMO, which are beyond the scope of this video and should be managed by an intensivist. And don't forget, in patients with ARDS, early prone positioning is a key intervention that can significantly improve oxygenation in these patients. How about when it comes to improving ventilation or CO2 removal? The two main variables we adjust are the tidal volume here and the respiratory rate, because they control minute ventilation. Now, always use predicted body weight, not actual body weight, to calculate to set the tidal volume. In ARDS, we aim for a lung protective strategy, 6 ml per kg of predictable body weight tidal volume. In most other conditions, a range of 6 to 8 ml per kg of predicted body weight is acceptable. Now, if more ventilation is needed, it's generally safer to increase the respiratory rate rather than the tidal volume to reduce the risk of volutrauma. But remember that the higher the respiratory rate, the shorter respiratory cycle is, which affects the IE or inspiration-expiration ratio. Now, how do we set the tidal volume in different modes? Again, in volume control and PRVC modes, the tidal volume is set directly and can be easily adjusted. While in PC pressure control control and pressure support modes, tidal volume is not set directly. Instead, it depends on the pressure gradient between the peak inspiratory pressure and the PEEP, and it depends on the inspiratory time. Now, to increase tidal volume pressure control mode, we simply increase the inspiratory pressure or peak inspiratory pressure in general, or decrease the PEEP, and carefully as this may affect oxygenation, or doing both. Just widen the pressure gradient between the PEEP and peak inspiratory pressure. The wider the gradient, the higher the tidal volume. The smaller the gradient, the less tidal volume. Or increase the inspiratory time to allow more time for lung filling. It's very similar in pressure support mode. Again, it's the same concept, just different terminology. So we increase the gap, we increase the pressure support setting, and just increase the gap between the peak inspiratory pressure and the PEEP, or increase the inspiratory time. But here it's not directly set, but can be adjusted by modifying the flow cycle threshold. We explained this earlier in this video. So lowering the flow cycle prolong the inspiratory time, while raising it, let's say from 25 to 50%, shorten the inspiratory time, and the shorter the inspiratory time is, the less tidal volume is, and the opposite is true. Let's wrap it up here. I hope this video gave you a strong foundation in mechanical ventilation and help make things clearer and more practical for your clinical work. Now, if you are ready to take it to the next level and truly master topics like peak inspiratory pressure, mean airway pressure, rise times, gas trapping, auto PEEP, inverse ratio ventilation, as well as how to assess weaning readiness and perform a proper weaning trial, then check out my full mechanical ventilation course. It's packed with real-world explanations, visuals, and tips I've gathered over the year of my work as a hospitalist. You will find the link below to the course, and I would love to have you in the course. If you like what you have watched so far, please give it a like, share it with your colleagues, and subscribe if you have not done so. Thanks for watching, and see you soon.